Hello everyone. Today we are going to discuss a very important topic which is valvular heart disease and its diagnosis without really focusing on the murmur part. It is a very important topic because as undergrad students we all have faced this thing during our rounds with the consultant. The consultant is saying that it is a murmur of, let's say, MS. It is a diastolic murmur of MS. Now maybe we are trying to listen to it, and we are not convinced that whether it is a diastolic murmur. First of all, we are not even convinced that whether that is a murmur or not. And if at all someone is able to hear to it, just because the consultant has said it is diastolic, some way or the other, your mind inclines towards diastolic. You do not know whether it is diastolic, whether it is systolic, and above all, you do not even know that whether it is a murmur or not. Right? You must have faced this thing. We all have faced that in our undergrad days, and not only undergrad days. It is a problem with the residents also, post residency, and even with the faculties also. So we can say with our own confidence that this is this kind of murmur we are listening, but that is not always the case with the reality, right? It is confirmed by the 2D echo, and many a times the echo results do not match or do not tally with our clinical results. So how do we really go about when the murmur, the diagnosing a heart disease with just the murmur? How good the sensitivity is, right? So the sensitivity is not that good because you cannot pick it up. So there is a study that has been conducted amongst a huge number of preclinical students, clinical students, interns, residents, and cardiology fellows. You see that the sensitivity of picking up a murmur correctly with the stethoscope, the preclinical students and the cardiology fellows, they have a wide difference in the results. And it is very obvious because the preclinical students, which is the first year MBBS student or maybe second year, third year, they cannot really understand what is the murmur. They might not even able to identify it, and it is very obvious that the cardiology fellows with the lot of cardiology training, they are able to clinch the diagnosis, able to correctly locate the location of the murmur and everything related to that. But the problem lies with this huge subset of people where there lies clinical students, interns, residents, and faculties, that we are not being able to really diagnose the heart disease with the murmur itself. So no matter how many times you boast yourself with the confidence that yes you can, but the study says something else. So while diagnosing a valvular heart disease, if at all you can, you can clinch the diagnosis with just by the murmur itself. It is the ultimate thing. But most of the time we cannot diagnose it with the murmur itself. We are very much confused. So we cannot go via that route, diagnosing a valvular heart disease, because ultimately at the end of your day, you have to establish a provisional diagnosis with conviction. So we will try to go via some other route, and by other route I mean we will try to logically determine the diagnosis by history and general examination and few relevant cardiological examinations which we can all do, right? So first of all, let us come to the historical differentiation of the four valvular heart disease that we are mostly given in the exams, right? So we have got two stenotic lesions, right? Two stenotic MS and AS, and two regurgitant lesions, which is AR and MR, right? So just the basic outline that in MS, the problem is between the LA and the LV, and the valve between them is stenotic. So the LA cannot pump its blood to the LV. That is the basic thing. In AS, there is a stenotic valve between the aorta and the LV. The LV cannot eject blood enough with enough force to the aorta because there is a stenotic pathway there, right? And in regurgitant lesions, the problem in MR is between LA and LV, but this time the valve cannot close properly. The mitral valve cannot close properly. As a result, the LV, anytime it ejects the blood, it has got two outlets, which is to the aorta and one is to the LA. Always some blood is regurgitating to the left atrium. In aortic regurgitation, the problem is with the closing defect of the aortic valve between the aorta and the LV. So the valve cannot close. As a result, the blood after being ejected to the aorta is always regurgitating back to the LV. And mind you, many a times while studying this valvular heart disease, we tend to forget the cardiac cycle, but the cardiac cycle is the key to understanding the physiology of all the valvular heart diseases. But let us now discuss with the history points that starting with MS, the MS patient, mitral stenosis patient is usually a young female, right? It is usually a young female patient. That does not mean that the disease does not occur in males, but what I am discussing today are the usual points, are the most probable points that will lead you to the diagnosis, because either way you are not being able to catch the murmur. This topic is all about that. If you can do the if you can diagnose the murmur correctly, then you don't need to know anything else, right? But this is for other candidates who cannot really diagnose or listen to the murmur. So MS, the patient is a young female, and in you see the age group of AS, it is a relatively elderly patient, right? Elderly patient, because it is a degenerative disease of the aortic valve. Do you get young patients? Yes, we can get young patient if it is a bicuspid valve. Bicuspid valve is the most common congenital valvular heart disease. It is patient can be a young patient, but usually in the exam, if we are listening, if we are given old patient, so AS is a one of the diagnosis, right? Just by the age group differentiation, if it is a young female, more likely she is having a rheumatic heart disease, and by rheumatic heart disease she will most likely be having a MS, right? These are clues, not definite clues but probable clues. MR, aortic regurgitation also, the age group is middle aged group, right? And the etiology can be rheumatic, but Marfan's disease is an important consideration to keep in mind. But anyway, in MR also it is middle aged group. And one important thing to remember in rheumatic heart diseases is that it almost always involves the mitral valve, right? So, if you are diagnosing a aortic stenosis patient to be of rheumatic origin, then it will be almost always involving the mitral valve also. You are missing out on the mitral valve. So before commenting the etiology as rheumatic, you should always keep in mind that there is a mitral valve involvement, without which a rheumatic heart disease is very unlikely, right? Now, so that is the main thing. So what is the symptoms? Now you see in mitral stenosis, the symptoms are dyspnea, orthopnea, PND, and hemoptysis. Now why it is so? Why it is so? You see the symptom. You cannot diagnose the disease with the murmur itself. You have to rely on the peripheral clues, the history diagnosis, right? So why is it so? Since the LA is getting dilated, it cannot pump or it cannot eject its blood to the LV, so the LA is getting overloaded chronically, and with its chronic overload, it will tend to release its pressure to its backward chamber, and in its just prior to the LA lies the pulmonary veins, and then we are having the lungs. So the first symptom, or if at all the MS patient is having symptoms, it will be dyspnea, orthopnea, PND, and hemoptysis, where the hemoptysis occur due to the rupture of the anastomotic channels that are being formed between the bronchial and the pulmonary circulation. Right, so these are the symptoms typical for MS, the starting symptoms, right? At the end, everyone will be having dyspnea some way or the other, but dyspnea early on, orthopnea, PND early on in the history is almost always suggestive of MS or LA involvement. Now, you see the regurgitant lesions. So let us also complete another stenotic lesion, which is the aortic stenosis. It is very easy to understand because the LV is not being able to eject its blood to the aorta. So the symptoms will be exertional dyspnea, angina, and syncope in that order, right? So patient will be dyspneic, then followed by angina because the LV muscle is trying to hypertrophy. As a result, it will outweigh its supply There will be a demand supply mismatch, patient will be having angina, and when it continues to a certain extent, patient will be having syncope as a symptom. This is typical for stenotic lesions between the aorta and the LV, right? And in regurgitant lesion, important thing to notice in regurgitant lesion is palpitation. That is a very important thing to notice in regurgitant lesion. Now, why it is occurring? Why it is occurring? So, palpitation is the unpleasant awareness of your own heartbeat. It is not almost always tachycardia like we tend to think. It can be during bradycardia also. Basically, what happens, it can be due to a defect or disorder in the rate. Your rate can go fast, your rate can go slow. It can be a disorder or it can be a defect in the force of contraction. Now, in regurgitant lesions, in aortic regurgitation, in mitral regurgitation, what happens is the blood is regurgitating back to the LV. From the aorta, it is regurgitating back to the LV. In MR, it is regurgitating the extra blood that has been pumped from the LV to the LA is being again regurgitating to the is being pushed to the LV in the next cycle. So the LV is being chronically overloaded. As a result, Frank-Starling law gets into its action. So you have palpitations. That is a very important thing. So palpitation is an important thing. At the end, you will be having, so this is bounding, the patient will be having awareness of the heartbeat. That is the thing. And this is the symptomatology. And the bounding pulse thing, we will be seeing that in the clinical signs. And the patient of MR will be having fatigue also because of low cardiac output, because LV is ejecting the blood, some of its blood to the aorta, but also a part of its blood to the LA. So as a result, he or she will be having fatigue. Now, the nature of dyspnea. So dyspnea, the nature of dyspnea, it will be late. It is a late feature due to LV failure. It will be a late feature. Why? Because in aortic stenosis, the LV is good. It prior to the LV is the LA, and the backward chamber to LA is the lungs. So to cause dyspnea in aortic stenosis, it is due to a LV failing, which is usually a late feature of the disease. The LV will hypertrophy initially, and at a later stage, it will start to fail. So in aortic regurgitation also, the LV failure is a late feature. Because why it is a late feature? Because LV will initially try to compensate for the extra amount of blood by hypertrophy. In aortic stenosis, the hypertrophy will be that of a concentric hypertrophy. In aortic regurgitation, it will be a eccentric hypertrophy. Ultimately, it will try to compensate, but finally it will fail, and it will be a late feature of the disease, right? And in MS, it will be an early symptom. Why? Because this is the LA, this is the LV, we have a stenotic valve here, and just so as a result, LA is getting chronically dilated, and just prior to the LA is the lungs. So if when the LA has started to fail, the LA will regurgitate, or the LA will push the blood to the lungs. As a result, you will be getting dyspnea. So that is the concept. So dyspnea is early feature. So this is the symptomatology of, and in MR also, the dyspnea is common, but it is not the early presenting feature. The early presenting feature is palpitation, right? Right. So, and so in this thing, the triad is not in this sequence actually. It will be initially angina, right? Because the LV will compensate by hypertrophy, it will eject, and finally it will fail. So there will be syncope or fatigability, and lastly there will be dyspnea, right? That is the symptomatology order. So palpitation is uncommon here. It is very much common in AR because of the reason that the Frank-Starling law comes into action, because the regurgitating blood from the aorta continuously keeps on going to the LV, and it is also due to in MR also. In MS, the palpitation is not due to force of contraction but rather a very important feature, which is AF. Now, most of the time in exam, we are given a MS patient. So, I am going to give you certain red flag signs, I mean the important pointers to the patient of MS. So if you are finding a young female, and the heart rate or the pulse rate is irregular, that is almost always atrial fibrillation. We can always check a pulse. That much clinical knowledge we have, that much clinical skill we have. We might not be able to diagnose the mid diastolic rumbling murmur of an MS. That is a very difficult task, but we can easily check the murmur, check the pulse, which is irregular. And if you are finding irregular pulse, irregular pulse, the most common sustained arrhythmia after sinus arrhythmia is your atrial fibrillation. So this combination is very lethal. I mean, not lethal, actually this is a very good combination for you, and it will almost always clinch the diagnosis of MS. Young female, atrial fibrillation, it is MS. The underlying, he or she can be having multivalvular heart disease also. But you can commit to MS just by these two clues: young female, rheumatic heart disease, and AFib. Very important thing to notice. So she might be facing palpitation because of AFib. So in aortic stenosis, angina is common because of LV hypertrophy. That is a very important feature. Chest pain can also occur because the LV is increasing in size. How will the chest pain occur in MS? It is actually none. If at all the chest pain, your patient is MS, still complaining of chest pain, it can be due to RVH, which is a RV type of angina, RV hypertrophy leading to RV type of angina. But that is not a common thing, and is rare in MR because MR is ejecting the blood to the LA, right? In AR, what happens? You are having a huge heart. It is sometimes called as the bovine heart. So chest pain is a common symptom. But chest pain due to angina is very much common in AS. Syncope is an early feature because of the low cardiac output, because the LV is not being able to eject its blood to the aorta or being able to eject a very small amount of blood. So as a result, the patient is experiencing syncope, or if not syncope, patient will be complaining of fatigability. That is the concept. This is rare in AR and rare in MS, but still fatigability, if not syncope, fatigability can be a presentation because of low cardiac output. That is an important feature because it is a stenotic thing. So less blood coming into the LV. LV is having less blood. So as a result, in the aorta, it will be ejecting less blood. So since it is a less cardiac output thing, patient will complain of fatigability, if not syncope. But syncope is an important prominent feature of AS. So you need to join the dots. While the patient is describing the symptom, you need to understand the chronology, and you need to join the dots because you only have these clues by the bedside. You do not have the murmur by your side. So and also in cough and hemoptysis, I told you that is a feature of very common feature due to rupture of the anastomosis between the bronchial and the pulmonary circulation in MS. That is a very common feature in MS. Fatigue due to low cardiac output is seen in AS, is seen in MS, and it is also seen in MR because of low cardiac output, everything. And edema, it is the early feature of edema. It is late in all, but you see in MS it is late, but in MS what happens is that it is all about the chamber prior to the lungs, right? Prior to the lungs is the pulmonary artery, and prior to the lung, that is the right ventricle. And if right ventricle will start to hypertrophy initially, And when it fails, it will give the back pressure to the RA, right? And then you will have JVP, you will have tender enlarged hepatomegaly, you will be having pedal edema, right? That is the concept. Now, so what the patient says that he in aortic stenosis, he will get dizzy or he will faint when he starts to walk uphill. It is very obvious, and this patient is always complaining of the hard pounding in his neck, and there is a thing called nocturnal angina that the patient complains typically in aortic regurgitation, right? And this patient of MS is always breathless when he or she lies down, and MR patient predominantly is complaining of palpitation. So this is a rough idea about how you really diagnose patients, or at least start to think in that line of a particular heart disease, right? So a young female with atrial fibrillation, with fatigability, with irregular pulse rate, a low blood pressure, and you are having signs of pulmonary congestion, you're having signs of RVH, you are having irregular pulsation in the JVP, you are having pedal edema, it is MS patient. Old patient, you should not think of MS in the first diagnosis. AS is, by the way, very easy to diagnose with the murmur also. So, old age patient, right, complaining of angina, complaining of fatigability, has a history of syncope once or twice, you start to think in line of AS. You then confirm it with the other clinical findings. In MR, the patient is a young patient, rheumatic origin, or patient can also have mitral valve prolapse also. But anyway, palpitation will be an important complaint of MR. Heart failure, the congestion in the lungs will be a relatively a late feature. So fatigability palpitation is important in MR. In AR, it is, if it is of rheumatic origin, then you will be always having a mitral valve. So there is a rule that a mitral valve is almost always involved in the rheumatic heart disease. Patient will be complaining of palpitation, patient will be complaining of nocturnal angina. So these are the important symptoms, and at the last, patient will be complaining of dyspnea. But dyspnea, mind you, is a starting feature or a very important prominent presenting feature of a patient of MS, because the lungs is just prior to the LA. Now, with the examination part, you can also try to differentiate between MS, MR, AS, AR, and I have also kept tricuspid regurgitation, but we will not go into the details of that because most of the time we are given these four diseases. So you see that in MS, like I said, that is a young middle-aged female. So mitral regurgitation can also occur in the same age group because it is a rheumatic origin, the most important cause. The second important cause is mitral valve prolapse. And if at all you are asked that apart from mitral valve prolapse, can you tell me a cause of acute MR, which is the rupture of the chordae tendineae that occurs in MI, that will be acute presentation, acute mitral regurgitation. But that patient will not be given in your exam. So this is elderly male, right? A male patient, can be a female also, but more common in male because it is of degenerative calcific in origin. But if it is a young patient, then the etiology is bicuspid aortic valve. The AR also is a middle-aged male, but not necessarily a male always. Now, important feature is pulse in MS, which is almost always irregular pulse. You should think of MS as the etiology of the valvular heart disease. In MR, it is a rapid pulse, regular pulse, but if there is an irregularity in it, so you should add the component of MS to MR if the pulse is irregular. That's the key. The atrial fibrillation is the clinching point of MS, right? Aortic stenosis patient will be having a low volume pulse. The pulse volume is not checked in the radial artery, it is checked in the brachial artery, it is checked in the larger arteries of the carotid artery. You can almost always check that. And by volume, it is not possible for you to comment, for any one of us for that matter, to comment on volume just by feeling for the pulse. You check for the pulse pressure, which is the SBP minus DBP. Almost we can all check the BP, right? So SBP minus DBP is your pulse pressure. It is 30 to 60 is normal, and if it is more than 60, let's say your systolic BP is 170, diastolic BP is 100, difference is 70, it is a high pulse volume, right? So we go via the that calculation thing. Do not think that you will be able to diagnose everything like it's written in the book. You have to we even the consultants use back calculation. No one can just feel for the pulse and tell accurately whether it is a low volume or a high volume or a normal volume. We always tend to know the BP, calculate the difference in our head, and then we comment on it. And also, that is the thing. So it is a collapsing water hammer pulse. We all know to check for the water hammer pulse. So pulse pressure is a very important thing in AR. Patients of AR, the BP, we write it like this: 160 by 40 by 0. 0 is where the Korotkoff sounds disappear. So while you check the BP of AR patient, the diastolic pressure is so low that you find the Korotkoff sound disappearing at 0, but 0 cannot be a diastolic BP. So we just take prior to that, which is 40, just take the fourth Korotkoff sound, we take it as the diastolic BP. So you see that there is a lot of pulse pressure. So if you are finding a huge pulse pressure, a high volume pulse, you can start thinking in line of AR, right? And in MS, the BP is low and the pulse pressure will definitely be low because SBP is low. As a result, the difference will be also low. The BP is normal in MR. It is a low systolic blood pressure. You see the stenotic lesions, they are causing a systolic decapitation because the cardiac output is low. Either from the LA, the blood is coming less into the LV, or in your stenosis, the LV is ejecting less blood to the AS, so the SBP is low. And wide pulse pressure is a very important feature of AR. JVP is irregular. We all can say JVP. See, what I am trying to say is that I considered even myself in your group, that we cannot diagnose the patient with murmur only. So, but we know how to check BP, we know how to check pulse, we know how to know the pulse volume, we know how to take history, we know how to check JVP. All these points, this 3 to 4 points or 5 points are helping us in diagnosing the patient. Then we can say that, well, this is a patient of MS, so he or she must be having a diastolic murmur. So in MR also, so MR, the JVP is normal unless there is RV failure, but it is irregular and elevated JVP in MS because MS, it has no other option. The prior chamber to LA is the pulmonary vein and the lungs. So definitely after the lung fails, the RV will take over and it will eventually fail and it will be present. So if there is a late LV failure, you will not get JVP. So JVP is an important point in your MS. Now this is another important point to know the apex beat. These are the ultimate points, right? So in apex beat is all about your LV, mostly about your LV. So in MS, the LV is paired in a purely MS patient. So it will be in a normal position, fifth intercostal space, half inch medial to the midclavicular line, right? In MR, what do you think? It will be within the fifth intercostal space, half inch medial to the midclavicular line? No, because the heart is enlarging. So it will be displaced, down and out, and diffuse. Down and out. Why down and out? Because it is a LV type of apex. It will be in the sixth space or maybe in the seventh space and outside the midclavicular line. In AS, it will be in the normal position because it is a concentric hypertrophy, but it will be a heaving or a sustained type of apex. See, apex beat will help you a lot in diagnosing the chamber problem. In AR, it will be definitely displaced down and out, because like I told you, in AR what happens, there is a huge heart because of the regurgitating volume. So parasternal heave, we all can know the parasternal heave by keeping our this thing, the ulnar border of the palm on the left parasternal location, we can feel for the heave. So that is an important feature in MS, and that is an important thing. Now, another important point, another very important point, we can also feel for the thrill. Thrill is felt by the, so we are feeling for the thrill by the, this thing, by the base of the fingers, like this, right? So we can feel for the thrill. We all can feel for thrill. So systolic thrills, the thrills that are palpable, that are mostly systolic in nature. Mostly systolic in nature. So if in the aortic area you can feel the thrill, so that is a systolic murmur lying underneath the thrill. So what is a thrill? It is a palpable component of a murmur. So if you are palpating a thrill in the aortic area, so it is very likely that there is a systolic component of the murmur, right? But there's a caveat, is that if you are feeling the thrill in the apex, right, it is almost always diastolic. And if it is diastolic thrill, so the murmur is diastolic and you are dealing with a rheumatic heart disease, so the diagnosis is MS. You get the point. Thrill palpable elsewhere is systolic in nature, mostly systolic in nature. But if the thrill is felt at the apex, it is diastolic. And if it is diastolic, then it is MS, because the murmur is also diastolic. And the only heart disease, the heart disease having a diastolic murmur at the apex is MS. So diastolic thrill at the apex, if you are finding, it is a rare thing to find. But if at all you are finding, and how to know whether it's systolic or diastolic? You time with the carotid. This much we have to do, right? We are not discussing much of the clinical methods in this video because that will be a lengthy one, but I know that you can check for the timing of the thrill by palpating for the carotids. So very important point is that if you are finding the thrill in the aortic area, well and good, it is aortic stenosis. Diastolic thrill at the base, it is a rare thing for the AR to occur, because the murmur of AR is also diastolic. We are not discussing murmur in this video at all. Just know that the murmur is diastolic in AR and in MS. So that is the point. So loud P2 is also a feature for MS. See, the MS is just shunting the blood, or just pushing the blood to the LA, to the lungs. As a result, the pulmonary vasculature will hypertrophy, will undergo certain compensatory changes, and pulmonary hypertension is a very important feature early on the disease. Later on, everyone can cause, because everyone will regurgitate, or everyone will push the blood towards from the LV to the LA to the lungs, but those are late features of the disease, right? Loud P2, we can diagnose it loud P2. So how do we know it is a loud P2? So P2 is as loud as your A2 in the pulmonary area, that is loud P2. Another thing, if you are hearing a split S2 at the apex, normally at the apex we hear lumped up, that is S1, S2, S1, S2. If you are hearing two sounds in the S2 at the apex, it is almost due to pulmonary hypertension, right? And these are the important points. And malar flush is not an important point in the Indian setting because of the dark complexion. And in AR, the important thing is your peripheral signs of AR, which is the collapsing pulse, the Quincke's sign, Durosio's sign. We can all read that from the book. Other clues are dyspnea, orthopnea, hemoptysis in MS, fatigue, dyspnea, palpitation in MR, angina, syncope, dyspnea in that order, ASD, right? ASD order in aortic stenosis, palpitation in AR, wide pulse pressure, water hammer pulse. So these 3P: palpitation, wide pulse pressure, and water hammer pulse. Very important, very important. Right. So almost we have come to the end of the video, right? I hope you have learned something or from this video. We can expand on these concepts in other videos also, but let us summarize few important points which I have felt myself while taking the history of valvular heart disease. So the first thing is that a valvular heart disease is a chronic process. I mean, the patients that you are given rheumatic heart diseases, these diseases are a chronic disease. Do you agree? Because you can argue that an MR can be acute, but that is not the typical rheumatic heart disease. MR can be acute in the settings of myocardial infarction. And if it is an acute valvular heart disease like MR or like AR due to traumatic AR, maybe due to aortic dissection, the patient will present instantly because the regurgitating blood will instantly instantly congest your lungs. Patient will dyspneic, patient will be hemodynamically unstable. So it is an acute thing. It will be not given in an exam. We are dealing with rheumatic heart diseases. So in rheumatic heart diseases, it is most of the time it is a chronic process. Almost always a chronic process. Patient will be having a long-term history, and it will so happen that patient is so much used to the symptoms, patient has compensated to the symptoms so much that many a times patient will be reluctant to give you the history if you do not probe the right point. So it does not present with constellation of symptoms unless acute. So if it is acute presentation, like if a patient is having a myocardial infarction, tomorrow he will get an MR, or maybe that day itself he is getting MR, he will be instantly dyspneic. But in MR, have we studied of dyspnea? Yes, we have studied in dyspnea in MR also, but it is a late feature. Important feature is palpitation, but in acute MR, dyspnea is an important starting feature. That will be not given in our exam. So it is not does not present with constellation of symptoms unless it is acute. But it can be acute, or patient can get admitted, a valvular heart disease, rheumatic heart disease can get admitted in your setting when it is precipitated by some arrhythmia, maybe atrial fibrillation has been precipitated, maybe an infective endocarditis have been precipitated, there is a fever or LRTI. These four things are the common precipitating factors of valvular heart disease. Right? Once you get atrial fibrillation, the LV end diastolic pressure will rise, the LA is itself overloaded in MS. Now the patient will start instantly feeling very much dyspneic, out of proportion of what he or she has been feeling for the last few years. Patient has MS, it is a chronic stenotic process of the mitral valve. Patient is experiencing MS. He or she is slowly decreasing his day-to-day activities to make him or her comfortable. He is doing well. Suddenly he gets a fever, someday an LRTI. These are preceding factors for atrial fibrillation. The palpitation, the heart rate increases. Fever itself can increase heart rate. The end diastolic pressure increases. LA, which is somewhat managing it is an enlarged LA, and now this extra amount of pressure will be transmitted to the LA, to the lungs, and the patient will present instantly. So always note for the precipitating factors in such cases in the history. So acutely regurgitated lesions do not give time to the patient. It has a very fulminant course, like I said. So regurgitated lesions cannot give you much time. If it is a chronic regurgitated lesion, then the LA, let's say we're dealing with MR. So the LV is ejecting blood to the LA, let's say 50 ml of blood every day. So LA will tend to enlarge over a time. But if the MR has occurred today, acute MR, all the blood from LV will try to go to the LA. LA is not accustomed to the huge amount of blood, so it will present acutely. Chronically regurgitated lesions are relatively stable and give us some time. So MS has a relatively fulminant course. Do you agree? Because the LA, the back chamber to the LA is the lungs. So it is in direct contact with the pulmonary vasculature and has a relatively fulminant course. And this aortic stenosis will be having this course. It is angina syncope dyspnea, or maybe a syncope angina dyspnea, depending. So syncope, pre-syncope, fatigability are the starting symptoms of AS. Sudden cardiac death is also not uncommon in this. You need to keep that in mind. MR has palpitation as the starting symptoms, and by MR I mean your chronic processes, that is the rheumatic heart diseases. AR is almost asymptomatic till the time the LV gives up. That is an important point. AR patient initially is asymptomatic because LV is accommodating the blood, it is ejecting. Later on, it will cause palpitation, and later on, patient will be having symptoms because when the LV fails, LV cannot hypertrophy mode, the heart failure has set in, then the AR patient will present. And lastly, the last point, orthopnea is not a specific symptom for heart failure because pregnancy, huge ascites, etc. can cause mechanical splinting effect of the diaphragm, and as a result, while the patient lies down, let's say a 36 weeks or 35 weeks gravid, a pregnant patient has lying down, she will be feeling orthopnea. That is not due to heart disease. And PND is very specific for heart failure. Paroxysmal nocturnal dyspnea is very specific for heart failure. And while pregnancy, you should, if a patient, let's say, is presenting to you at 45 years, and you know that the patient is having MS, MR, everything. So important precipitating factor, you in the history you should be noting that whether during her delivery of her child, whether it was uneventful or eventful, that is during normal vaginal delivery, the cardiac output, the exertion on the heart increases to a lot more extent. So valvular heart diseases precipitate during the peripartum period, during the delivery period, right? So valvular heart disease has that kind of typical history during, so always take obstetric history in such female patients, very important. So that was all mostly from my side. It is a huge topic, but I hope if you can take the screenshot of this chart from this video, you can benefit from this video, because at the end of the day you need to diagnose the patient, no matter whether you're diagnosing it with the murmur or via history and back calculation and everything, you have to diagnose it in the exam. So that was it from my side. Keep reading. We will expand on this video in my subsequent videos also. So till then, take care. Happy studying.